Hello everyone. Today's topic is on scalp. So here in this image we can see the covering of the top part of the skull, which is called as calvaria. So this covering is called as the scalp. Scalp is nothing but the soft tissue covering which is covering the calvaria, that is the top part of the skull, and we can see here several layers of the scalp. On the other side, we can also appreciate the meninges covering the brain deep inside the calvaria, that is within the cranial cavity. Now let's begin the scalp with the extent. So the scalp extends anteriorly from the superciliary arches where our eyebrows are present. So the forehead is the common part between the face and the scalp. So anteriorly it extends from the superciliary arches, posteriorly up till the external occipital protuberance. So posteriorly up till the external occipital protuberance. On each side we are having the nuchal lines. So posteriorly up till the nuchal lines and external occipital protuberance. Laterally the scalp extends inferiorly up till the zygomatic arch. So the term scalp, it is applied to the soft tissue which is covering the vault of the skull or the calvaria of the skull. So now let us understand the layers of scalp. The name scalp, the term scalp itself stands as an abbreviation for its layers. So S stands for the skin, C for connective tissue, A for aponeurosis, L for loose areolar tissue, and P for pericranium. So the skin of the scalp, you can see the skin here. These are the various layers of the scalp. The skin, connective tissue and aponeurosis. These three layers are tightly adherent to each other because of the connective tissue, and these three layers form as a single unit which are together called as scalp proper. They are together called as scalp proper. So talking about the skin of the scalp is quite thick and hairy except over the forehead. So the skin is similar to that of palms and soles. The only difference is it has got numerous hair follicles. So it has got numerous hair follicles, and hair follicles are always associated with the sebaceous glands, and also the sweat glands are also numerous in scalp. So because it contains numerous sebaceous glands, as a result the scalp is the common site for sebaceous cyst. So here we can see the layers again: the skin, then closed connective tissue underneath it, then aponeurosis, which is a part of a muscle, all three together called as scalp proper. Then the loose areolar tissue over which the scalp is moves. Finally, the pericranium, which is the covering of the bone, which is nothing but the periosteum of the calvaria. So these are the layers of scalp. Next, as I said earlier, the scalp is prone to sebaceous cyst. Next, about the connective tissue. The connective tissue, here we can see this is a schematic image to understand the connective tissue. It is dense and it is nothing but the superficial fascia of the scalp. So it is dense and superficial fascia of the scalp, and it is divided by dense fibrous tissue into the septa. We can see the septa, which is with these septa firmly binds the skin with the aponeurosis and occipitofrontalis muscle. So the fibrous septa, we can see it divides this layer into a small numerous pockets which are containing the lobules of fat, and the blood vessels, nerves of the scalp lie in this area. So it is highly vascular structure, and the layer anchors the skin to the third layer, that is the occipitofrontalis and Galea aponeurotica. So when the scalp is cut in this layer, if there is any superficial cut cutting the connective tissue, usually results in a profuse bleeding, So the bleeding, however, can be stopped by pressing against the underlying bone. So it contains numerous arteries and veins, and if any cut is difficult to stop bleeding because the blood vessels are attached to the fibrous septa of subcutaneous tissue. So the only way to stop bleeding is applying the local pressure to the scalp is the only satisfactory method to stop bleeding. Next, about the third layer, aponeurotic layer, which is the third deepest layer of the scalp proper, and it is firmly adherent to the skin by means of dense connective tissue, and this layer anteriorly continues to form frontalis muscle and posteriorly occipitalis muscle. Aponeurotic layer is otherwise called galea aponeurotica. Galea means a helmet in Latin. So it is otherwise called as Galea aponeurotica, connecting the two frontal bellies from the occipital bellies, where they are attached to the frontal bellies are attached to the skin of the eyebrows and blends with the muscles of the eye. Frontalis, one thing to be noted here, the frontalis is not having any bony attachment, whereas occipitalis posteriorly we can see the attached to the nuchal lines which are present on each side of the external occipital protuberance. So here we can see the gaping of wounds. So the wounds in the scalp do not gape usually unless if there is a deep cut transversely cutting the aponeurosis. So because of the transverse cut of the aponeurosis is under the tension because of frontalis and occipitalis muscle. So because of this occipitofrontalis muscle, the wounds tend to gape, means the lips of the wounds tend to separate. And if the aponeurosis has been divided, only if the cut is there in the aponeurosis transversely, then only the wounds tend to gape, and hence the aponeurosis must be closed with the sutures. So surgical intervention is needed. It has to be closed by means of sutures. Here we can see the frontalis muscle without any bony attachment, blending with the other muscles and attached to the skin of the eyebrows. Posteriorly, we can see the occipital bellies on each side attached to the nuchal lines on each side. So, if there is any fluid collection in the loose areolar tissue, because the frontal muscle is not having any bony attachment, the fluid gravitates around the eyes, whereas posteriorly the occipitalis is not having any it is having attachment, so the fluid cannot excavate beyond the nuchal lines. So that is one thing to be noted. Next, the layer is the loose areola, which is the fourth layer of the scalp. The layer of loose connective tissue separates the aponeurotic layer from the pericranium, and this layer facilitates the movement of the scalp proper. That is the top three layers together called as scalp proper. So it helps in the movement of the scalp proper over the calvaria. Because of its consistency, the infections tend to localize and spread through the loose areolar tissue. So that is the reason the loose areolar tissue is otherwise called as dangerous layer of scalp. So here we can see the loose areolar tissue is traversed by the emissary veins. So this layer is traversed by the emissary veins, which are connecting the veins of the second layer, that is from the connective tissue veins of the scalp with the veins of the intracranial dural venous sinuses. So this layer is the dangerous layer of the scalp because the blood in this, suppose if there is any pus collection in this layer, it easily spreads into the dural venous sinuses via the emissary veins, which may be sometimes fatal also because the thrombosis may go inside and block the dural venous sinuses. So the layer of loose areolar tissue beneath the aponeurotic accounts for the free mobility of the scalp proper. So additionally, it is like an easy plane or cleavage in injury. So usually the plane of cleavage is along the loose areolar tissue, that is the subgleal layer or subaponeurotic layer. And when the hairs are caught in the machinery, the scalp proper is avulsed in this plane, that the surgeons mobilize the scalp flaps at this plane, in this plane. So loose areolar tissue is the dangerous layer of the scalp, and we can see as the frontalis is not having any bony attachment, suppose if there is any blood collection deep in the loose areolar tissue, it gravitates around the eyes because the frontalis is not having any bony attachment, causing discoloration around the eye, which is called as black eye. So the discoloration of the eye, it is not only because of hematoma or blood collection in the loose areolar tissue. It can be sometimes due to direct blow or punch over the eye, or it can be due to the fractures of the base of the skull, which results in raccoon's eyes. Next, the last layer is the pericranium. The pericranium, we can see it is the covering of the bone, and it is nothing but the periosteum, and it which is covering the outer surface of calvaria. It is attached to the bones, but it is loosely attached. We can easily strip off the pericranium, but except at the site of the sutures. At the site of the sutures, the pericranium continues with the fibrous structure within the suture. Further, it reflects below the bone as the endocranium, which is the inner covering of the bone. So that is about the pericranium. It is loosely attached to the bone, but it is firmly attached to the sutures and sutural membranes, where it continues to form endocranium, which is nothing but the periosteum covering the inner aspect of the calvaria. Now let us understand different types of blood collections, which are nothing but the hematomas. So one thing here we can see, these are the skull bones, calvaria, and we can see the dural venous sinus and the brain, and here is the dura mater. Suppose if there is a fracture of the bone without the tear of periosteum or pericranium, the blood accumulates underneath the pericranium, taking the shape of the bone. That is called as cephalohematoma. Cephalohematoma takes like, for example, if there is a fracture of parietal bone, the hematoma appears to be like a shape of the parietal bone, because the periosteum is still intact and the blood accumulates along the surface of the parietal bone, and where it is limited by means of sutures, because the periosteum is tightly adherent to the suture. The next, suppose if there is further tear of the periosteum, then the fluid starts collecting in the loose areolar tissue, which is called as subaponeurotic hemorrhage or subglial hematoma. And subglial hematoma, that is fracture of the cranial vault, is associated with the tearing of the dura and pericranium. In such cases, the blood from the intracranial hemorrhage communicates with the subaponeurotic space of the scalp through the fracture lines. You can see through the fracture lines it communicates, and the signs of the cerebral compression do not develop unless the subaponeurotic space is fully filled. So till this gets fully filled, there are no signs of compression of cerebral hemorrhage. There is no cerebral compression, because this act like a safety valve hematoma. So subaponeurotic space, unless it is fully filled with the fluid, till that time the brain is not compressed. So that is the reason the fourth layer or the loose areolar tissue is called as the safety valve hematoma. And if the CSF accumulates instead of blood, then the condition is called as cephalohydrocele. If the CSF accumulates, it is called as cephalohydrocele. And we can see the caput hemorrhage also here, where the fluid collection or the blood collection is in the subcutaneous tissue. It is called as caput succedaneum. So here we can see a schematic image, again understanding various types of blood collection. So caput succedaneum, here we can see it is the collection of blood in the subcutaneous tissue, that is called as subcutaneous edema, which is common in the occipital region, and it occurs due to the parturition, that is, it is a common trauma during head passing through the birth canal and due to the interference of venous return. So due to the venous engorgement, we see this generalized swelling which is often associated in the occipital region, and the margins are partly defined. The margins are partly defined, and generally the edema subsides after few days after birth. So nothing to worry about this. The edema automatically subsides few days after birth. Let us understand the innervation of the scalp, that is the nerve supply of the scalp. On each half of the scalp is supplied by 10 nerves, 5 in front of the ear and 5 behind the ear. Out of 5 nerves, 1 is the motor and 4 are sensory. The motor innervation is to the occipitalis muscle, that is occipitofrontalis muscle, which is innervated by the 7th cranial nerve or the facial nerve. So the branch of the facial nerve which is in front of the ear is the temporal branch of facial nerve, and the branch which is posterior to the ear is the posterior auricular branch of facial nerve, which supplies occipitofrontalis muscle which is present within the scalp. And next is about the sensory supply. The sensory supply is by two major sources. One is the fifth cranial nerve, that is from the cranial nerves, and posterior to the ear is by the cervical plexus. So there are 4 sensory in front of the ear and 4 behind the ear. The 4 sensory nerves are supratrochlear nerve and supraorbital nerve. You can see the supratrochlear here, and supraorbital nerves, and which are the branches of ophthalmic division of trigeminal nerve. And we can see laterally zygomaticofacial and zygomaticotemporal nerves. Zygomaticotemporal is a branch of maxillary division of trigeminal, and then auriculotemporal nerve, which is a branch of mandibular division of trigeminal nerve. So these are the nerves supplying in front of the ear the scalp. Posterior to the ear, the scalp is supplied by that is the greater auricular. We can see the greater auricular over here. The greater auricular nerve supplies posterior to the ear and in front of the ear, the skin here in the angle of the mandible as well. So greater auricular with the root value C2, C3. Then lesser occipital nerve, which is also having the root value as C2 from the cervical plexus, and then greater occipital nerve, which is the thickest cutaneous nerve in the body, which supplies most of the scalp from the posterior aspect. Greater occipital nerve is also having the root value as C2, and third occipital with the root value of C3. So these are the nerves which are the branches of cervical plexus which supply posterior part of the scalp. Let's see the blood supply of the scalp. So the blood supply, each half of the scalp is supplied by 5 arteries. So the scalp is rich in blood supply. It is a highly vascular structure, and from on each side of the midline it is supplied by 5 arteries, 3 in front of the ear and 2 behind the ear or the auricle. In front of the ear, the 3 arteries are supratrochlear, supraorbital and superficial temporal arteries. Supratrochlear, supraorbital are the branches of ophthalmic artery, which is in turn a branch of internal carotid artery. Superficial temporal is a branch of external carotid artery. And posterior to the ear, the 2 arteries are posterior auricular and occipital artery, which are the branches of external carotid artery. So the scalp is the free site of anastomosis between the branches from the internal carotid and external carotid artery. That is the site of anastomosis between the 2 carotid systems. So that is about the blood supply of the scalp. Let us understand the venous drainage. The scalp on each side of the midline drained by the veins which are accompanying the arteries. So they have similar names as arteries. And the veins are like supratrochlear vein and supraorbital vein, and they join to form angular vein. Angular vein continues to form the facial vein, and we can see the facial vein communicates with the cavernous sinus by means of dural venous by means of pterygoid venous plexus. So that is about the deep facial, and you can see the facial vein finally joins with the anterior division of retromandibular vein to form a common fascicle which drains into internal jugular vein. The other veins of the scalp are superficial temporal veins. Superficial temporal veins joins with the maxillary vein to form retromandibular. Retro means behind. So the vein is present behind the mandible within the substance of parotid gland. So it is called retromandibular vein. Retromandibular vein, as it reaches the lower end of parotid, it divides into anterior and posterior division. Anterior division joins with the facial vein to form common fascicle which drains into internal jugular vein. Whereas the posterior division joins with the posterior auricular vein and which joins to form external jugular. External jugular drains into subclavian vein. So posterior auricular vein drains the posterior side of the scalp. Still more posteriorly, it is drained by the occipital vein, and occipital vein drains into suboccipital venous plexus. Occipital vein drains into suboccipital venous plexus. So that is about the venous drainage of scalp. One thing to be noted here, the scalp veins are valveless veins. So the flow of blood is bidirectional. Next, about the lymphatic drainage. Just like how we studied about the nerve supply, blood supply of the scalp, the lymphatics also we can divide is in front of the ear and posterior to the ear. So in front of the ear, the lymphatics of the scalp drains into preauricular lymph nodes, which are superficial parotid lymph nodes. Posterior to ear, posterior auricular lymph nodes, which are otherwise called as mastoid lymph nodes. And further, they finally drain into the principal lymph nodes which are present in the neck, called as jugulodigastric and jugulo-omohyoid lymph nodes. Let us understand still more clinical aspects about tissue expander. Tissue expander is the plane of cleavage in the scalp. The scalp is placed between the aponeurotic, the plane of cleavage is between the aponeurotic and periosteum. So the tissue expander in the rest of the body is an avascular subcutaneous. In the rest of the body, it is an avascular subcutaneous layer. In the scalp, the tissue expander is subaponeurotic layer, that is between the aponeurosis and the periosteum, that is in the loose areolar tissue, which is the line of cleavage. So the tissue expander is very important in scalp grafts, hair implants, and hair transplantation and all. Let's see few questions. A 25-year-old man is brought to the hospital after a glass injury to the scalp. Close evaluation reveals the injury to the veins of the scalp, responsible for equalization of intracranial pressure and selective cooling of the brain. So which of the following possible features of these veins best enables these functions? Relatively thick muscular wall, lack of valves, lack of communication with the pterygoid venous plexus, linear flow of pattern of blood. So the answer is lack of valves. Because of lack of valves, the flow of blood is bidirectional. So here are few teaching points. The valveless nature of the emissary veins provides bidirectional flow of blood from the inner sinuses to the outer veins of the scalp. So that is the reason it causes cooling of the brain, and also it prevents the accumulation. So upon reaching the extracranial circulation, the blood is cooled by evaporation occurring on the surface of the head. The next question here it is, tissue expander in the scalp is placed between. So I hope you can answer this question. It is placed between aponeurosis and periosteum. So the plane of dissection or insertion of plane of cleavage is the loose areolar tissue. It is usually relatively avascular plane, and also it is the site for tissue expander, because the other three layers are tightly adherent, forming scalp proper. The nerve supply of the scalp, except, so among this which is not a nerve which is supplying the scalp, so we know the answer is infratrochlear nerve.